Hello, friends. My name is Kiran Kumbhar, and welcome to TIF Talkies by the India Forum. I will be a host on the episodes dealing with public health and health policy in India. I am a medical doctor and historian of medicine, and currently work as a lecturer and postdoctoral associate at Yale University's South Asian Studies Council. In these public health focus episodes at TIF Talkies, we will speak with guest scholars from multiple disciplines whose work deals with the many topics and subjects under public health and health policy. By picking the brains of these scholars, we will attempt to understand the intricacies and complexities of the Indian healthcare scenario. These intricacies often never make it to the mainstream discussions on health in India, and we will learn a lot of that in on TIF Talkies. In the episode today, we are looking at the famed private sector of medical services. This major part of our healthcare system is, of course, regularly in the news. But most recently, we saw a lot of discussion on the private sector after the Rajasthan state government passed its Right to Health Act, and medical associations of mostly privately practicing doctors held several demonstrations against this act. To talk more on the private sector, including a bit on the reaction to the Rajasthan Right to Health Act, our guest in this episode is public health researcher Dr. Indira Chakravarthi. So, first, let's hear a short introduction to Dr. Chakravarthi and her work.
So, right now, of course, I work as a public health researcher. In fact, I have been working as a public health researcher for almost 2 decades now. 2000 is when I kind of registered for a PhD in public health. But I am basically my education is in chemistry and biochemistry, and what is popularly known as the natural sciences. I'm not a social scientist, and that kind of over time led to an interest in technology and issues of medical technology. It was kind of about a decade-long process while I was doing a PhD in biochemistry. So, due to various questions regarding the role of technology in health, I kind of moved into public health. And as I said, after kind of a decade-long process, working with some NGOs on occupational health issues, actually, and where one was trying to understand about chemicals and their impact on workers' health, etc. Anyway, to cut a long story short, so I've been working as a public health researcher now for nearly 2 decades, as I said, since I started my work on medical technology and public health, my dissertation, actually, PhD dissertation. I'm based in Delhi, though I did work for some time in Pune with an NGO there, Sathi. I'm largely based in Delhi, where I have worked with several other NGOs, and my work has largely, my interest has and remains technology and medicine and public health. And then also because of my association with the health activists here and with several health networks here, I kind of took up some studies and projects in private healthcare in India, which, as we can discuss, occupies again such a central place in all the discourse on health. So that's how kind of I've been working largely on on the private healthcare sector in India.
When we take a historical look, the medical world in India has always been dominated by private practitioners since independence, and even before then. It is crucial to note, however, that when we casually say private healthcare sector in our everyday discourse, we almost always mean big corporate hospitals or the good old nursing homes and smaller clinics often run by doctor couples. And so when someone cites a common statistic, like, for example, in India, 70% of all outpatient visits are made to a private facility, we might be led into believing that corporate hospitals and private doctors' clinics take care of 70% of our nation's outpatient services. But that is actually misleading because this category of, in quotes, private healthcare services includes a large number of community based and informal, as they are called, healthcare practitioners. Of course, sometimes they are also derisively called quacks in the mainstream discourse. So, long story short, the private sector in Indian healthcare is much bigger and much more heterogeneous than just private hospitals. That is the first fundamental aspect of this sector we need to know. And the second fundamental aspect is that we actually do not know quite a lot about this sector. That is, there is very little organized and systematic data on the number of private practitioners, clinics, nursing homes, and hospitals in our country. Let's hear Dr. Chakravarthi explain these issues in more detail.
It's not that the private healthcare sector is this one big homogeneous entity out there. It's the heterogeneity again, which has been described by others, also is that of one is based upon education and training. So we have what is called the informal private healthcare sector, and then the formal sector, right? Um, uh, Now, the informal largely refers to the untrained uh, practitioners of certain folk systems. What you would be better acquainted with as a trained medical practitioner, right? Uh, mm, mm. But the formal sector is what is normally we refer to when we talk of the private healthcare sector. Uh, 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 so I will not go into the issue of the informal sector or the when we say that they are untrained or poorly trained quacks and so on. That can be discussed separately. Here, if to focus on the formal private healthcare sector in India, that also is pretty diverse. And the diversity along several axes. Basically, one is we have different systems of medicine, so we have practitioners of different systems of medicine, again something you would be familiar with. Those practicing Western medicine, what we call here Western medicine, right? Modern scientific medicine or allopathic medicine or Western medicine, these different terms that are used. We also have trained practitioners of Ayurveda, of Unani, of Siddha and homeopathy. So the diversity in terms of different systems of medicine. So, and you have practitioners, then the diversity in terms of the size of the institutions. Largely for a long time we had individual practitioners, as I already mentioned, but you also had different sizes of hospitals, nursing homes, small to medium to big to much bigger, 500 or 1,000 bedded and so on. So in terms of size, that is another axis that brings in the diversity. Then their legal status in terms of, are they for profits or are they registered as not for profits? The not for profits commonly known here as charitable institutions, charitable hospitals, right? Not for a long time, not for profit was not used. Actually, they were simply known as charitable hospitals or dispensaries. So that then that is one, whether they are not for profits or for profits. And then within, and now in this also, there is really a range, and especially if you start looking at the for profits, we we have, as I again, even small, which is what comes through from our study, even the from small institutions to very big 500 plus hospitals getting registered as for-profit companies. Plus, you have now in among the for-profits, you could have Indian hospital companies that are multinational companies which are setting up hospitals in other countries too, and at the same time also certain foreign companies setting up hospitals in India. So that is the kind of diversity that we have. It feels bad talking in generalities about this important sector, right? We are not being able to give precise numbers when we start talking about the private healthcare sector and about private hospitals, which is what I wish to draw attention to, that while the private healthcare sector has definitely grown in size and in composition and in all these forms that I talked about now, we still don't have systematic data collection. We still don't have state-wise registries, which we can go to and say, okay, fine, there are this many, there are this, say, 4,000 private hospitals in Maharashtra. This is their ownership. This is their, status. These are the services they provide. Uh, these are the number of patients they cater to. So it's not just in terms of this kind of numbers, number of doctors employed, personnel employed and all, but from a public health viewpoint, what does it mean then? Because epidemiologic data then also we don't have. It is such a large sector. We now know that 70-75% of the care is being provided by the private healthcare sector, but we still do not have very reliable, comprehensive information. And why is it so? The policymakers, international institutions, everybody talks of engaging with the private sector, and how we'll have you find business related data as to how the industry is growing by this much percent, and it's going to grow up to this much percent, and it is worth this many billions of rupees. And how to whom is that data useful, from a health systems perspective and for planning for health? How, where does that kind of data fit in, and projections are made also about how many more doctors and how many more nurses we are going to need, right? But what exactly would be the basis for those projections is something, I've tried to understand how these projections are made, because on the one hand, when we try to look for some data on just simply numbers of hospitals or their district-wise distribution or their state-wise distribution, it is just impossible to get. We simply don't have that kind of data. So diseases, why I'm bringing in the epidemiology uh, aspect also, for as public health researchers and even for planning. And if you look at this very important public health problem we have of tuberculosis and even malaria. Now, researchers keep saying that so much of the treatment is happening in the private sector. But to estimate that, how many private practitioners, are the private practitioners maintaining their records? Is there reporting in the various surveillance systems? Now, we don't get that kind of data from the private healthcare sector. All the data that gets reported on the Central Bureau of Health Intelligence and our national health profile, all that disease profile data is based on reporting from the government institutions. So this is a very big gap about the private healthcare sector, I think, which I wish to point out in this. So I'm not able to say very much. We know there are rural urban differences, but what is the extent of that is so difficult to uh, say for us.
Many experts, especially economists, often claim that the private healthcare sector in India is so substantial, we need to have more and more of the so called public private partnerships, or PPPs. Dr. Chakravarthi has done a lot of work on the functioning of such PPPs. I asked her about her thoughts on them and also put to her the tricky question of how successful PPPs have been in India, if at all, and whether they really bring any discernible changes in healthcare access and quality for ordinary Indians.
It it could be said that um, it is not that the government did not engage with private partners or with non-government agencies, non-government organizations prior to this PPPs becoming very popular in a sense in the policy circles, or being adopted and implemented. It's say again, late 1990s and the decade of the 1990s and 2000 onwards, is when these major changes happen, right? Wherein PPPs start getting advocated and promoted and also adopted by the government, uh, within the healthcare system, uh, in terms of what was popularly called contracting in services, hmm, or contracting out of some services to the private sector, engaging personnel, healthcare personnel on contractual basis. And so, uh, but prior to that, I mean, prior to the 1990s also, whether in the family planning programs, non-governmental organizations had been involved. So it's probably the nature of engagement and the intensity of engagement probably increased, changed post 1990s with the adoption of the reform process. Hmm. Uh, I see one of the studies again, which I undertook with an organization here, where with in several states we tried to look at the engagements of the government with private partners for several different uh, services. It's it, it's uh, how successful has it been is a very big question. For instance, the study, the aspect we looked at was, I mean, I'm not able to go into the details of that, but I will just, explain with this example of the Delhi government engaging with private partners to provide dialysis services, right? Uh, Now, what the study threw up was that many aspects of it didn't take off at all. The the uh, the technical aspects of the attention gets focused on the technical aspects of drawing up the contract, with the private partner, or even prior to that, inviting tenders, and then whether those who bid for this contract, whether they fulfill the requirements, and after doing that, are there systems in place to monitor whether the private provider is providing the services that they have they have been contracted to provide? Hmm. There were a lot of gaps in that. Hmm. And uh, what emerged was that, is it based on a proper assessment of the needs of the public health services? What are those needs? Um, who are the private partners who would be able to cater to them. And then what exactly would be the terms which would be favorable ultimately for the patient, for the person who is coming, whether they are getting the services that they need on time. Like, for instance, the selected provider had to provide dialysis services in several hospitals, in about 6 or 7 hospitals, I think. But the provider had started it only in 2 or 3 hospitals. And there was a very long waiting list even in those hospitals, right? And the quality of care, now, quality of care is something which is harped upon a lot, that it is the private sector which provides good quality of care. It is private providers who can provide good quality of care, and it is counterposed with the public sector, the government hospitals not being able to do it, right? But here, in our interviews with patients, there was much left to be, desired even about the quality of care. Simple things like the the actual dialysis was taking place at one hospital. For medicines, they had to go to another hospital. So, and another issue of the people who were employed to the nurses, and the patients felt that they are not trained enough. Uh, so, but what I would like to say is there are instances of these kind of public-private partnerships that have not worked, and the respective state governments have actually then terminated those agreements. Right, especially in Karnataka, and even in Delhi, there were other instances for provision of emergency ambulances and all, which had to be terminated because the private providers didn't abide by the terms of the contract, didn't provide the services in the way. So there are instances of that also. So the public-private partnerships have really, in the provision of clinical care, have not worked in the way that they were projected initially, right? But that part is also not told or highlighted, that the fact that they have not worked in the way they were drawn up then. Now, of course, it has changed. I mean, the nature of the engagement has changed, in the sense where, because of the introduction of this the insurance mechanism, right, where this whole split of this, that's another important development, right, where the government will finance the purchase of healthcare from private providers. So that's how this engagement or this public-private partnership has changed. So the insurance is the mechanism, right, where the government provides the resources and you access your care at a private hospital itself. So, which is again another form of public-private partnership, right?
Dr. Chakravarti mentioned that government-funded health insurance schemes like the Rashtriya Swasthya Bima Yojana, which nowadays is called the Pradhan Mantri Jan Arogya Yojana or Ayushman Bharat, are in many ways a form of such PPPs. So, what do we know about such insurance schemes? And do they hold any promise of long term positive impact on public welfare?
The rollout of these insurance programs, starting with the RSBY, the Rashtriya Swasthya Bima Yojana, which was the earliest government, what is called the publicly funded health insurance schemes, which was initiated and which was implemented by the Ministry of Labor. There's a whole history of the introduction of RSBY at that time to address the healthcare needs of the informal sector, of the large informal sector population in the country. Right. But since then, and that and the various state health insurance schemes. Again, in many states which introduced it, states like Andhra and Maharashtra had its health insurance schemes. So these have all been actually very well studied and documented. And what are the kinds of hitches, roadblocks, barriers? The most important aspect being, have they reduced out of pocket expenditures? That was one of the major, that has been one of the major goals, right, in introducing government insurance schemes, the publicly funded health insurance schemes. Have they reduced it or not? Now that aspect has been pretty well studied, and a large number of uh, studies are there which show that uh, uh, it uh, there is scope, there is a lot of scope for improvement, right? Now, have they all been addressed in the most recent this Ayushman Bharat, this Pradhan Mantri Yojana health insurance scheme, the central level scheme? uh, there are studies about that also. I mean, uh, am not, I mean, I have myself not gone into them in depth, but we now, there's the National Health Authority has been set up separately. Uh, there are quite a lot of problems in that also. Now, interestingly, one aspect was that the through insurance, the or the availability of financing through insurance will be one of the ways to promote growth of private sector in smaller cities, or in the what is called the underserved areas where the private sector does not go. So it was hoped that with this will give some kind of a push and an incentive, the availability of money through insurance. But that again has not happened to the desired extent. Like again in Maharashtra itself, uh, uh, it did emerge that uh, where the public hospitals are not there, the private hospitals are not also there in some of the underserved areas. And another barrier was where from rural areas, again, if we come to that point, from rural areas, even with the availability of insurance, people were still reluctant to use it, because again, they have to come to the bigger cities to make use of that insurance funds for any illnesses. So there are instances where people again forego treatment. So these many of these issues, again, there would be state to state differences, right? When we talk of the health system, there are a lot of interstate differences, from Tamil Nadu and Kerala, and even some of the northeastern states being outliers in some ways, when you compare them to the EAG states. So we have to keep sight of that.
So, well, in such a context of healthcare in India, wherein the majority of our people still suffer serious issues in terms of affordability and access to decent quality and respectful care, came the recent Right to Health Act of the Rajasthan government. Most listeners of this podcast will probably be aware of this act and the many debates it has spawned. I was curious to know what Dr. Chakravarthi thought of it, so let's hear her take on these debates.
So I'm afraid on the actual issue of the Right to Health Act, that it has been passed by the Rajasthan government, I think, to the best of my knowledge. Um, but so per se, the uh, there has been a lot of protest by one section of the medical profession, right? Doctors in Rajasthan have been protesting, and um, so about this act and about this bill itself, the Right to Health Bill of Rajasthan itself, I would not be able to. I would not wish to comment much on it. I really have not gone very much into the details of the exact points of the difference of the doctors. But one of the points which I picked up, which has been raised in the context of Maharashtra also, where we looked at the passing of the Clinical Establishments Act, right? Uh, Maharashtra has a Bombay Nursing Homes Registration Act, and at the same time, there's also this demand that the government, the state government, should adopt the Clinical Establishments Act that has been enacted by the union government. At that, so this resistance and this protest by doctors to the Rajasthan Act is actually not very new, because even when the government tried to pass the Clinical Establishments Act, at that time also there was significant opposition to it, again by sections of the medical profession. But regulation itself, if you see, what emerged from our studies, which we have talked about, is again, several axes. So the first one is sections of the doctors feel that it is mistaken to say that the healthcare sector is not regulated, and then they will tell you the whole list of laws that they have to comply with, right? And their whole experience then with the bureaucracy, with respective bureaucracies, while that act is being but in abiding with all those laws, which are related to the physical infrastructure and to building laws and fire safety laws and a range of that. So, but when it comes to two issues, is one is about regulating the rates, to which there has been a lot of opposition and stiff resistance, and from the medical profession saying, we are professionals, and the fees of no other profession is regulated, so why would you, do you seek to regulate only the fees of medical professionals? That, and two is, even in Rajasthan, what is happening is that this requirement that emergency medical care needs to be provided as soon as the patient comes in, and without asking for fees and money. So that is a major issue, where then the point of the doctors is then because of their experience with the government, they say ki, who is going to pay for it? Because at that point we cannot ask the patient. That is according to this, to statutory requirements. So, and these were the issues at that time also, even during the Clinical Establishments Act, and even in the Bombay Nursing Homes Registration Act, when there were attempts to bring in rate regulation. So one is regarding this issue, right? But interestingly, what has happened is, accompanying these changes within the private healthcare sector, the heterogeneity in terms of size, and the coming in of the whole process of, in the process of corporatization, what has happened is the differences between the smaller hospitals, the individual doctor hospitals, and the bigger hospitals. There again, now you see that there is a division within the medical profession also. It is not a totally homogeneous group. So the smaller hospitals feel that it is no longer a level playing field, where they are now having to compete with the corporatized sections, which have much larger resources at their disposal.
If you would like to learn more about the Right to Health Act, which received assent from the Rajasthan governor on April 12th, we have included links to a few good explainers on it in the episode description. So friends, that is all for today. We will return in a few weeks with a new guest to learn more about public health and health policy and their many complexities and intricacies. Thank you very much for listening.